All right, so today we're going to talk about best practice physiotherapist-led rehabilitation for FAI syndrome and early hip osteoarthritis. Yep, so I just have some disclosures, financial disclosures. So I do receive funding from the British Journal of Sports Medicine and honorarium as an editor. I'm also the co-lead of the GLAD Australia program, which we receive research funding for, but I don't receive any personal funding. And my research is funded through the Australian government. And again, that's the only personal funding I receive from that is for my salary. Otherwise, the funding is all related to research costs. So before we start talking about physio treatment for young adult hip pain, I thought that it's probably good to start with a discussion on contemporary classification of hip pain. So the hip pain classification has developed over the last decade through a number of research consensus statements that have been published over that time. So we had the Doha Agreement in groin pain, which I'm sure everyone there is aware of, in 2014. That was followed by the Warwick Agreement for FAI syndrome in 2016. Then the Zurich Agreement on hip-related pain in 2018, followed by the Lisbon Agreement specifically on imaging for FAI syndrome in 2020. And then the Oxford Agreement in 2022 on primary care morphology. And then just in the last couple of months, the ESCA Agreement on hip and groin pain was published as well. And each of those consensus agreements have had a publication that has arisen from that. So a lot of those publications published in the BJSM, but they're really, really well worth a read if you do have a particular interest in the classification of hip pain. But just to explain how each of those consensus agreements build on the classification of hip pain, it's worth delving into each of them to see what was agreed at the time. So prior to the Doha Agreement in 2014, there was a huge amount of variation in the terminology that was used to describe hip pain. So, for example, I might say that a patient had a Gans lesion, and Enda, who might have been in Ireland at the time, might have called that same thing a CAM lesion, or he might have called it a sportsman's hernia or athletic pubalgia. So it was really hard to have a standardised classification of pain, and therefore it was really hard to know whether we were comparing the same thing or different things. So having a standardised consensus was really important for us to be able to conduct research, but also for clinicians to be able to understand that they were speaking the same language. And so what the Doha Agreement decided was that hip or groin pain could be classified as 5 clinical entities. And those clinical entities were pubic-related pain, adductor-related pain, iliopsoas-related pain, inguinal-related pain, or hip joint-related pain. If we skip ahead now, we skip over the Warwick Agreement and skip to the Zurich Agreement, which was published in 2018. What that agreement did is it took the classification of hip joint-related pain from Doha and further classified hip joint-related pain into one of 3 classifications, those being either femoroacetabular impingement syndrome or FAI syndrome, which is what we're going to be speaking about today. The second classification was acetabular dysplasia or hip instability. And the third classification was other intra-articular hip joint pathology, but without the changes in bony shape that we see in FAI syndrome or acetabular dysplasia. If we then skip back in time to 2016, where we had the Warwick Agreement for FAI syndrome and also the Lisbon Agreement in 2020, what those agreements did is they took that first classification of hip joint-related pain, which is FAI syndrome, and said that for a patient to have FAI syndrome diagnosis, they must have all 3 of positive imaging findings, which the Lisbon Agreement suggested should be either diagnosed as an alpha angle diagnosed by either an AP pelvis or a Dunn 45U. They must also have symptoms. So there's no such thing as asymptomatic FAI syndrome. Patients need to have pain. And they also must have clinical signs that are seen in FAI syndrome. And then in 2022, the Oxford Consensus on Primary Care Morphology was published, and that gave a really nice description on what that idiopathic care morphology that we usually see in FAI syndrome looks like. And then finally, the ESCA consensus was published earlier this year, and that sort of brought everything together in what had been published in a number of the separate consensus statements to say that those 5 classifications of groin pain that were agreed on in Doha were the right thing, and that we should then break hip joint related pain down into those 3 further classifications of FAI syndrome, acetabular dysplasia, and other pathology without changes in bony shape. But what I just want to reinforce is that while it's really nice on paper to classify all those things in neat, separate little boxes, what we actually see in real life is an overlap of those things. So it's really, really common to have a number of these things coexisting. So 1 or 2 or more of the other groin pain entities may coexist with FAI syndrome and or hip dysplasia and or commonly chondrolabral pathology. So a classic example is we might see someone who has the CAM morphology typically seen in FAI syndrome, but alongside that, they may have a shallow acetabulum that would be typically seen in hip dysplasia. So you can actually have those 2 things coexisting, even though they're described separately as a separate classification of hip pain. I think it's important too to have an understanding of what the burden of hip pain is across the lifespan before we sort of delve into what sort of treatment options are best for FAI syndrome. So if we think about the burden of hip pain across the lifespan, we do tend to see different presentations at different time points. So what we see in adolescents might be different to what we see in young adults, and then that might be different to what we see in middle-aged and older adults. So classically in the sort of teenagers and young adults, we might see acetabular dysplasia or hip instability. Once people are in their 20s, that's when they'll often present with the signs that you typically see of FAI syndrome. As they get older and head into their 30s and 40s, that's when we start to see those chondrolabral pathologies that might actually represent early hip osteoarthritis. And then finally, in older adults, that's when we'll see more advanced hip osteoarthritis. If we look at the burden of each of those one at a time, what we see when we look at hip dysplasia is that 80% of people who are affected are women, and 1/3 of those adults will progress to hip replacement within 10 years of their diagnosis as a young adult. And so while the average age of hip replacement in the general community is 65 years, the average age of those with hip dysplasia who go to hip replacement is 35 years. So they're really impacted as young adults. When we look at the burden of FAI syndrome, it's been classically considered to be, I think, a condition that affects young male athletes. But in reality, it's pretty close to being 50-50 men to women being affected. Those that do have FAI syndrome have an up to 80% increased risk of developing hip osteoarthritis. And when they present, which is often in their late 20s, they can have pain and quality of life scores that are similar to people with end-stage hip osteoarthritis. And that's at a point in their life where they're often busy and active. They may have young children, playing sport, have busy jobs, and so on. Once people sort of present into middle age and we start to see those signs of early osteoarthritis, again, it affects around 50% men to women. And what our research showed that if those men and women go to hip arthroscopy, and at the time of hip arthroscopy, they have those signs of early osteoarthritis present, and they're aged over 40 years, they're 4 times more likely to progress to a hip replacement within 2 years of that index arthroscopy. And then finally, looking at the burden of hip osteoarthritis, we know that 30% more women than men have hip osteoarthritis, and 30% more women than men will progress to hip replacement. So the burden of hip OA is bigger in women than men. And this is the point in time at the lifespan that we're going to be focusing on today in our presentation. So if we sort of summarise the classification and burden before we move on to treatment options, we know that hip joint related pain in young adults can be classified as either FAI syndrome, hip dysplasia, or pathology with normal morphology. And while each classification has a unique presentation, people can present with an overlap of classifications, and each of those classifications may have features of early hip osteoarthritis. So it's really important to get an accurate diagnosis and an evaluation of impairments if we're going to be able to develop effective treatment plans for each individual patient that's affected by hip joint related pain. So if we move on now to what we should be using to inform our best practice physio-led treatment for FAI syndrome or early hip OA, I think it's important to remember that while we're talking about FAI syndrome, there is often this coexistence of those other entities of hip and groin pain. And the other thing that's really important to consider is this treatment pyramid. So the treatment pyramid basically says that everybody should be doing physical activity, whether they're injured or not, whether they're a patient or not, that every human being should be remaining physically active. That those who have some sort of injury will probably also need to do some sort of exercise therapy, which is targeted rehabilitation that has a specific therapeutic goal. And that surgery should really be reserved only for a small number of patients who may have that injury. But I think what we see often in our clinical practice in Australia, and it's different all over the world, but often what happens is surgery is potentially considered by patients very early in their physiotherapy treatment. And so as physios or patient or non-surgical clinicians, it's really important that we have a good understanding of the evidence for surgery so that we can give our patients a really balanced view on what the best treatment option is for them. And so the first thing that I want to discuss as physios is whether patients should be having surgery, and it's important that we have an understanding of the evidence of hip arthroscopy for FAI syndrome and labral and chondral pathology, which is early hip OA. So when our patients come to us and say, look, I'm coming to you as a physio, but I'm thinking about having surgery, what are the questions that patients most commonly ask us about that decision? So my patients often say to me, what are the likely outcomes with surgery compared to non-surgical treatment? What is the risk for and of increased pathology with surgery? What are the risks of other comorbidities with surgery? How much improvement will be gained with surgery? Will I be satisfied with the results of surgery? And then lastly, and I think really importantly, will I be able to get back to sport at the same level as I was pre-injury if I have surgery? So let's look at each of those questions one at a time. So if we look at the likely outcomes of surgery compared to non-surgical treatment, this is a meta-analysis from a systematic review that we published a couple of years ago in BJSM. And basically with this systematic review, anything that sits on the left-hand side of the vertical line favours arthroscopy, and anything on the right-hand side favours physiotherapy. And what this systematic review showed was that the physio-led interventions in these studies were less effective than surgery at 6 months, but that difference was lost at the 2-year follow-up time point in the studies that we were able to include in this meta-analysis. So then the next question is, what is the risk of getting increased pathology if you have surgery? So this was data that was published last year from the Australian Fashion RCT. So what this study did is it used delayed gadolinium enhanced MRI of cartilage, or DeGeMRIC. And so DeGeMRIC is a method that is used to quantify the quality of the cartilage. So this was an RCT where they recruited 99 people who had FAI syndrome, and they were comparing arthroscopic surgery to a physio intervention. And what they found was that at 12 months, there was no difference in cartilage quality between the groups. There were some issues with this study, though, in that they had to stop follow-up MRIs because there was concerns about the safety of the dye used in the DeGeMRIC MRI scan. But with the evidence that they have, they found no difference in cartilage quality between the groups, whether they had surgery or not at 12 months. So it's unlikely that those having surgery have better or worse quality 12 months post-op than those that don't. But I think it's important to know that we don't yet know if cartilage changes progress with more time. So will we see different results as time goes on? But just watch this space. I do know there's going to be some really interesting papers coming out that will give us some more information about this question over the next couple of months. So then what about the question about the risk of other comorbidities with surgery? So this was the study that was published a couple of years ago in BJSM. It was a study that was conducted in the Army in the United States, where they measured comorbidities before arthroscopic surgery and then again 2 years after arthroscopic surgery. And what they found, sorry, my light's just gone off, I've just got to move. What they found was that there was an increase in comorbidities after hip arthroscopy. So they found that mental health conditions increased by 84%, chronic pain conditions increased by 166%, sleep disorders increased by 111%, and systemic arthropathies increased by 132%. So I think what this tells us is that we do need to watch our patients who have those yellow or orange flags. However, it's important to remember that we don't know whether these patients would have had the same outcomes with non-surgical treatment. So this wasn't a randomised controlled trial. So we can't say that surgery definitely caused this increase in comorbidities. It was just that it was noticed that there was an increased comorbidities after treatment in these patients. So then the next question is how much improvement will be gained with surgery? And so we can look at the RCTs that have been conducted to try and answer this question. So this first RCT was conducted in the United States. And what they found was that at 6 months, the physio group had improved by 8 points out of 100 on the IHOT 33, and the surgery group had improved by 15 points. The fashion RCT at 12 months found that the physio group improved by 15 points on the IHOT 33 and the surgery group improved by 20 points out of 100. And then finally, the study that was conducted in Oxford found that at 8 months, the physio group had improved by 4 points out of 100 on the HOS ADL score, whereas the surgery group had improved by 13 points. If we then look at satisfaction after surgery, this was a study that was conducted using data from the Danish hip arthroscopy registry. And this study included Danish patients. And what they found was that after surgery, 1 year, the Hagos subscales ranged between 54 and 70 points out of 100. And they found that 70% of the patients in their registry had gained improvements by 10% or more, which is the minimal important change of those Hagos subscales. But I think importantly, only 38% of patients reached Hagos scores that were considered to be within the normal range that healthy controls would get. And so if we put all this together, what we can see is that after hip arthroscopy, there can be up to 20 points improvement out of 100, but most people don't get back to normal. I think it's important though to note that no one has yet measured patient satisfaction after physio either. So watch this space for that. And then I think the really important question that patients want to know is, will I get back to sport at the same level that I was pre-injury if I have a hip arthroscopy? So this was again study from the Danish hip arthroscopy registry, and they included patients who were aged between 18 and 30 who had FAI syndrome and had a cam resection and a labral repair. And what they found is that 50% of those patients returned to their pre-injury sport at the pre-injury level that they were at. But only 17% returned to optimal performance within that sport. So they surveyed patients afterwards and asked them, if you're playing sport at the same level that you were pre-injury, do you feel like you're playing as well or at an optimal level? And only 17% of patients felt like they had returned to optimal performance. So if we summarise the evidence for surgery, what we can say to our patients is, should they have hip arthroscopy? Well, probably not as a first-line treatment. They should always try a high-quality rehabilitation program first, but sometimes the high-quality rehabilitation program isn't enough, and so surgery might be necessary in cases where we're certain that those non-surgical treatment options have been exhausted. But when we're helping patients make that decision, what we need to consider is that there are risks associated with surgery, that the patient-reported outcomes can improve by up to 20 points, which is quite significant, but they're not likely to return to normal. And really importantly, not everyone returns to sport at the pre-injury level they were at with optimal performance as well. So knowing all of that, well, what is the contemporary evidence for physio treatment for young patients with hip pain and in particular FAI syndrome? So to answer this question, we can draw on different bodies of evidence. So we can look at consensus recommendations, we can look at systematic reviews and randomised controlled trials, we can have an understanding of what patients present with impairments, and we can also see what patients are telling us themselves with their own voices. Remembering that we overlay that treatment pyramid where everyone should be given physical activity, people with an injury should also be given exercise therapy, and only a small number of people should have surgery. And then that'll give us our best evidence for physio-led treatment for FAI syndrome. So let's look at consensus recommendations first. And I was lucky to take part in this, the Zurich consensus on physio-led treatment for hip-related pain. And what we said in that consensus was that exercise-based treatments are recommended. So exercise should be the cornerstone of all of the treatment that we do. It should target patients' impairments and dysfunctions. It should include lower extremity and core muscle strength as well as motor control. We should have a specific focus on dosage and progression, and also should make sure that we restore and optimise range of motion as well. The consensus also said that exercise treatment should take at least 3 months. So treating someone for 4 weeks or 6 weeks is not going to be long enough. It also said that we should be using things such as patient-reported outcomes, measures of physical impairment, and measures of psychological and social factors to monitor whether or not our treatment is being effective. So if we're using patient-reported outcomes, that the HAGOS and the IHOT-33 are the recommended PROMs that we should be using. But we also should be taking physical measures of muscle strength, using dynamometry measures, and also range of motion, using devices such as inclinometers to see whether or not our treatment is having the desired effect. We also recommended that patients should be doing physical activity, and that often includes sport. And so that as clinicians, we should be developing a plan very early in the rehab stage to get people back to physical activities and also to return them to sport if that's what they want to do. And that the consensus published by Claire Ardern and colleagues in 2016 forms a really, really good basis on how you can return patients to sport. And we'll talk about that in a little bit more detail later on in the presentation. And then the final recommendation was that as clinicians, we should be discussing patient expectations, using shared decision-making about different treatment options and providing them with education. So that specifically our education should include discussion on the relationship between pain and hip joint structure, that there are intra-articular findings prevalent in both symptomatic and asymptomatic people, that there are associated risks with both surgical and non-surgical treatment, and then also let patients know about the expected magnitude of improvement and the likelihood of the duration of treatment that they're going to need as well. And that all of this should be done under an umbrella of shared decision making. So the next body of evidence we can look at are the systematic reviews and RCTs. So we published this systematic review a couple of years ago in BJSM, where we looked at outcomes for physio-led interventions. So this is a forest plot of our findings for treatments that went for 6 weeks. So when we pulled the data on 6 weeks from these pilot RCTs, what we found is that the physio-led interventions were no more effective than control interventions when they were of 6 weeks duration. However, when physio treatments were 3 months or longer, what we found here was that the physio-led interventions were more effective than control interventions for function when the treatment went for at least 3 months. But it's really important to recognise that all of the trials in this systematic review were only pilot studies, so very small, underpowered studies. So we have now finished an RCT where we looked at the effects of exercise for FAI syndrome. So this RCT is currently being written up for publication and hopefully will be published in the next few months. But just to present the findings of this for you now, these are the results of a study called the PhysioFIRST study. So the PhysioFIRST study recruited 154 people who had FAI syndrome who were aged 18 to 50 years, and they were recruited based on the Warwick Agreement. So to be included, patients need to have an alpha angle of at least 60 degrees. They needed to have pain at least 3 out of 10 and a positive Fadir test. And what we did is we conducted a double-blinded parallel group superiority RCT. So both treatment groups got the same amount of physio treatment. The actual treatment varied between the groups. So what we looked at was the effects of a 6-month physio-led intervention, which was a targeted strengthening program, compared to a physio-led intervention with a standardised stretching program on hip-related quality of life and perceived improvement at 6 months. So what happened with this trial is that for the first 3 months, both groups saw the physio every week and did a supervised exercise session, and also did 2 exercise sessions at home, either an individualised progressive targeted strengthening program or a standardised stretching program. And then for the second 3 months of the intervention, patients saw the physio once a month, where they got a checkup on their exercises, and they were also given a gym membership to be able to go to the gym and complete their exercises 3 times a week in their own time. So here are the results of our study. So if we firstly look at the results of our primary outcome, which was hip-related quality of life measured using the IHOT-33, So this is the results for the targeted strengthening group in the dark red colour. And what we can see is that the targeted strengthening group improved from an IHOT score of around 55 points up to an IHOT score of around about 78 points over the 6 months. So a really nice improvement. But if we look at the results for the stretch group, which are in yellow, we can see that there was absolutely no difference between the groups. So what we saw was a between group difference of only 1.6 points out of a possible 100 points. However, we saw a within group change of almost 22 points for both groups. So both groups got really large improvements in their hip-related quality of life score. Now we have the results for perceived improvements in pain. So for this figure here, we have the strength group at the top for their perceived improvement in pain, and then the stretching group underneath for their perceived improvement in pain. And the groups that I've circled, which are the medium blue and the dark blue, represent the number of people who said that they were either somewhat or much improved for pain after 6 months. So what we found was that 72% of the strength group felt like that they had perceived improvement in pain, compared to 52% of the stretching group. And so what that means is that the strengthening group had almost 2.5 times greater odds of feeling like they had a perceived improvement in pain compared to the stretching group. However, when we looked at the perceived improvement in function, there was no difference between the groups. So here we have the results of our secondary outcomes. So what we found was that there was a significant difference between the groups favouring the strength group, where the strength group had greater improvements in hip abduction strength and hip adduction strength, and also hip external and internal rotator strength, which I haven't presented here. But there was no difference between the groups for improvements in hip extension strength or any of our functional measures or fear of movement. So what our RCT found was no difference between the targeted individualised strength program and a standardised stretch program on hip-related quality of life at 6 months in people with FAI syndrome. But our strength group did have 2.3 times greater odds of having improvements in perceived pain compared to stretching. Both groups showed improvements that were much larger than the minimal clinically important change in hip-related quality of life at 6 months. So what does this mean clinically? Well, as I said, both groups did have a large within group change of hip-related quality of life, and this is bigger than all of those previous RCTs that I presented earlier. So if we remember back to the American RCT, they saw an improvement in their physio group of 8 points, and the fashion RCT saw an improvement using the same outcome measure in their physio group of 15 points. So probably what this means clinically is that 6 months of supervised exercise, along with education about the benefits of exercise and also giving patients the confidence to exercise and undertake physical activity, might be more important than the specific exercise program that you give them, because it seems as though both strength training and stretching can be beneficial for quality of life. But we do need to remember that the strength intervention was more effective for improvements in perceived pain and also improvements in muscle strength. So if a patient needs to get stronger, we probably should be giving them strengthening exercises as part of their rehabilitation. So then the third body of evidence that we can look at is knowledge of patients' impairments. Now, when we're thinking about impairments, I think as clinicians, we're really good at using the biopsychosocial model, but we also need to consider the psychological and social impairments that people can have as well. So if we look firstly at the biological impairments that people have, Andrea Mosler led a really nice paper that summarised the physical impairments seen in people with hip pain. And what she found was that people with FAIS had muscle weakness in all of their hip muscles. They also had reduced power in their hip flexors and extensors. They had weakness in their trunk muscles, reduced hip range of motion, poor functional performance, and also reduced physical activity capacity. If we now look at the psycho in the biopsychosocial model, there's a few different studies that we can draw on here. So this was a study that was done in people with chronic hip pain, of which the majority had FAI syndrome. And what this study showed was that better self-efficacy and kinesiophobia was associated with better hip-related quality of life, and it explained 38% of the variance in scores. So that means that That's self-efficacy, so being able to believe that you can do something about your pain, and kinesiophobia, so not being scared to exercise, explained an enormous amount of how people's quality of life was. Then we published this paper last year where we looked at kinesiophobia or fear of movement in people with FAI syndrome. And what we found is that the people who had greater kinesiophobia, so they were more scared or more fearful to move, had worse hip-related and general quality of life. They had more pain and they had worse self-reported physical function. But interestingly, their actual physical function was no different. So they felt like they had worse physical function, even though it wasn't any worse. And importantly, the effect on kinesiophobia was bigger in women than it was in men. And so it seems as though fear of movement is associated with worse pain and function and poor quality of life, but particularly in women. And then this was a qualitative study published in the BJSM. And this study included people with hip pain who had been referred to see an orthopaedic surgeon. And what most people in this study said was that they believed that their pain was caused by exercise. And they also believed that they had damaged hip structures, and those damaged structures were the thing that was causing their pain, and that they'd had multiple ineffective treatments. And over half of them believed that because their pain was coming from their damaged structures and because exercise was making their pain worse, there was nothing that they could do themselves to help control their symptoms. And so this had a really negative effect on their mental health as well. So if we put all of these psychological elements together, it seems as though that the fear of exercise and the fear of further damage creates this complex interplay between the physical impairments and the psychological impairments. People are fearful to exercise and move, so they become more physically impaired, which then makes them more psychologically impaired. So we get this vicious cycle between the two. And finally, if we look at the social aspects of the biopsychosocial model, this is where we can draw on patients' voices. And this was a qualitative study that we published a couple of months ago where we asked patients with FAI syndrome what they believe their physio-led treatment should look like. And what patients told us is that they did want to know what the cause of their hip pain was. So they wanted an accurate diagnosis. And most of them had imaging, and they wanted their imaging clearly explained to them. They told us that they wanted to have clear expectations about their long-term management and prognosis and wanted to know that early in the piece. And they also wanted to know how often and for what duration physio would be required. And I think really importantly, how to avoid surgery for their hip if they could. They told us that they expected to go to the physio for at least 2 to 3 months, but were happy to go for up to 6 months. They were happy to commit to 3 home exercise sessions per week. They were also happy to pay for the gym if it was going to be helpful for them, and that they expected to be able to return to sport and activities that they hadn't been able to do because of their pain. They also told us they were happy to use technology to enhance their treatment. They were also happy to plan treatment around their individual lifestyle, and they wanted help with being able to do that. They wanted to use quick equipment that they could access easily. And I think really interestingly, they were all happy to use over-the-counter medication to manage particular spikes in their hip pain that they would get. And then my colleague Diogo Gomez has just published his paper in the JOSPT where he looked at patients' expectations for physio treatment. And what Diogo found was that 52% of patients, so most patients, came to the physio for an exercise-related goal. And the most common goal was to be able to exercise without pain. But other goals also included goals relating to activities of daily living, relating to pain, and also relating to physical function. But I think the really important thing from this study was that 2/3 of patients did not expect their physio treatment to be beneficial. So they were happy to give it a go, but they didn't think that it would work, which I think is a little bit of a worry for us as physios if that's what patients believe. I think it's also if we remember back to what we said about the burden of hip pain in women, it is larger in women than it is in men. So I think as clinicians and when we're providing physio or exercise-based treatments, there probably are specific things to females that we need to consider. So we need to remember that women do have differences in pelvic morphology. We also need to remember that women might have gynecological causes of hip pain that are unresponsive to exercise. So, for example, they may have conditions such as endometriosis, which gives them pain in that lower pelvic area. We also need to remember that if women have recently had a baby, they may well have pubic pain and instability that we need to consider in our exercise prescription. So taking care with single leg exercises and exercises such as the Copenhagen hip adductor exercises. We also need to remember that there can be hormonal influences on women's pain, so things like their menstrual cycle, use of contraceptives, and also perimenopause. That fear of exercise is greater in women, and that there are some social impacts on the capacity to exercise that are different in women compared to men. So if we put all of that together, what is considered to be best practice contemporary physio for FAI syndrome? And so the key components of a physio program can be split again into the biopsychosocial. So if we look at the biological elements, people need to be doing hip muscle strength, trunk muscle strengthening, functional retraining, movement retraining, and cardiovascular loading or physical activity. But we also need to consider the psychological elements of our treatment. So make sure that what we're asking patients to do aligns with both their goals, but also their values and what they're happy to do. We also need to remember that we might need to refer patients on for additional psychological management or management of distorted pain presentations, and make sure we include education as part of our treatment. And then finally, we need to consider the social aspect. So make sure we tailor the treatment to suit the patient's setting and preferences and expectations, and also include them as part of that shared decision making. So if we look at each of those individually now to finish things off, if we look at the bio first of all, when we're thinking about hip strength, here are some examples of exercises we can use to progress hip adduction strength, exercises we can use to progress hip extension strength, exercises we can use to progress hip abduction strength, and exercises that we can use to progress hip flexion strength. When it comes to the trunk, here are some examples of some variations on side plank that we can use to progress people from an early stage to a more advanced stage of trunk muscle strengthening. And for functional retraining, it's important that we progress people from double leg exercises to more challenging single leg exercises with increased impact and loading demands and also increased complexity. With movement retraining, we need to look at people's movement in walking and running, particularly if they do want to get back to running. And some of the modifications that we can consider are things such as step length and step rate, where shorter steps and a faster cadence might reduce potential bone stress pain, but also look at external factors like hills. So, for example, if someone's going uphill, it will increase the amount of hip flexion that they need, and that might be provocative for that patient. So you might need to look at the environment in which they're exercising in. But also consider distal factors. So, for example, we know that a reduced or a stiff ankle into dorsiflexion will mean that people will use increased hip flexion and hip adduction and internal rotation as a strategy when they're doing one-legged tasks, which could increase hip impingement. And we also know that reduced calf strength will increase loads on the hip joint. And so they're distal factors that you might be able to influence to help influence someone's response to rehab. We've talked about this already, but remember that we need to provide both physical activity and exercise therapy for people with hip pain. So while they're both critical, they're not the same thing. So physical activity is any bodily movement that requires energy expenditure that's considered to be beneficial for everybody, whereas exercise therapy is a form of physical activity that's prescribed and progressed to achieve a specific therapeutic condition. We also should be aiming to return these people to play and performance because that's what they've told us they want to do. So if we think about a timeline of return to play planning for an athlete, obviously the athlete has been thinking about this probably from the time that they started to get their pain or their injury. And most likely their coach has also been thinking about when are they going to get back to play right from the start. Now, as clinicians, we will enter this process at various times along the timeline, but we should be thinking about this as soon as we meet the patient as well and beginning to plan for that return to play at the initial assessment. So we should be using shared decision making and start that planning at initial assessment. But there are good frameworks such as the START framework that can help you plan that. So what the START framework does is it weighs up the risk assessment. So that's the available evidence that we have about the knowledge of risks of return to sport versus the risk tolerance, which is the individual's patient's tolerance for risk. So is someone prepared to take a big risk, or are they risk averse? Because that will make a big difference as to how soon they feel ready to return to sport. And if we think about the psychosocial elements of treatment, education is a big one, and we should be telling our patients about the poor relationship between structure and symptoms. That structural change might be important for some patients, but not all patients. So we should be giving them support to overcome their fear of exercise. Telling them that they're going to need to maintain their physical activity throughout the rehab process. Also letting patients know that it's normal to have flare-ups of symptoms and they won't be totally pain-free with exercise. It's actually okay to exercise with a little bit of pain. And that they're going to need to do ongoing, probably strength and functional training that we should try to normalise as part of their normal fitness and not rehab. Making sure we tailor exercise for their lifestyle. And for some patients, we might need to refer them on for psychology or for pain management or for surgery, in addition to our physio treatment. So while I've described the biological, the psychological and the social separately, I think it's really important to remember that all of those things influence each other. So if we can improve someone's strength and their ability to exercise, that will probably reduce their fear of exercise and increase their self-efficacy to be able to exercise. So those things all have definitely an interaction with each other. There are some specific considerations for women that we need to include in our rehab. So we need to remember that if women don't respond to exercise, it might indicate non-musculoskeletal causes of pain. That if women have recently had a baby, we need to consider pelvic instability. If women are perimenopausal, they will intuitively lose muscle mass. So we may need to change the dose of our strength training to give them heavier resistance and lower repetitions to increase muscle mass. And similarly, women who are perimenopausal may need to eat up to twice the amount of protein to normal to help increase that muscle mass. Women as well who are perimenopausal may not be able to train in hot environments, so be really careful of when and where you're asking them to train. Also remember the social impacts of pregnancy, maternity leave and breastfeeding on women. I think it's important just to finish off to acknowledge there are limitations in our current knowledge of physio treatment for hip pain. So we have only one single full-scale head-to-head RCT for hip pain in FAI syndrome, which was the PhysioFIRST trial that I presented. And we don't have any other full-scale RCTs on other causes of hip pain. And no studies have examined the female-specific potential influences on responses to exercise either. I think as physios, we do need to do better. So we do need those full-scale RCTs. But I think what we need to do is come together and develop standardised effective approaches and leave our biases and our focuses on things that one particular person tells us to do behind. Because what that will mean is that the surgeons and physicians, but also importantly the patients, will have confidence in physio. So we won't have 2/3 of patients not believing the physio will help them, because patients and physicians will know that if they go to physio, they're going to get good quality care. Then we need effective ways to scale up and implement that effective, good quality care. We also need better decision-making tools to stratify patients. So we need to know early on whether someone's likely to respond to physio or they're likely to need surgery as well. And then I think we need to importantly listen to the patient. So not everybody wants surgery, but also not everybody can commit to or afford at least 3 months of physio. So we do need equitable funding models, and this does vary a lot from country to country. So final slide for today, what is contemporary evidence for physio treatment for FAI syndrome? Well, I think we need to remember that hip joint pain is classified as either FAI syndrome, dysplasia, or other pathology with normal shape, and that FAI syndrome and early hip OA do impart a large burden on young adults. Hip surgery should not be the first line treatment, but it can be necessary in cases where the non-surgical options have been exhausted. We do have some emerging evidence now for exercise therapy for at least 3 months for FAI syndrome, but we need to make sure we remember the biopsychosocial elements of treatment, particularly the fear of exercise and the fear of damage that can be caused by exercise. Don't forget the female-specific elements as well when we're treating women with hip pain. And lastly, I think as physios, we need to unite to develop standardised effective treatments. Just a huge thank you. This is our team of hip researchers at La Trobe Uni. Just getting the light to switch on again, who have all contributed to this big program of research. And I'd just like to say thanks again for the opportunity to come and speak to you today.